Good afternoon.
Oh,
Thank you for.
oh,
Oh, go ahead, Verna. I'm sorry.
no, go ahead. Start us off. Sorry.
Okay. Good afternoon. Thank you for joining us for today's ACU Office Hours webinar on suicide prevention in primary care. We're honored to be able to co-host today's presentation with the American Association of Teaching Health Centers. My name is Rick Brown, and I am the Associate Director of Communications and Membership with the Association of Clinicians for the Underserved, and I'll be your host for today's webinar. For those of you who are new to ACU, we are a transdisciplinary membership organization uniting clinicians, advocates, and organizations in the shared mission to establish a robust and diverse workforce to help transform communities to achieve health equity for all. We do that by providing advocacy, professional education, training and technical assistance, and more to develop and support clinicians in the healthcare workforce caring for America's underserved communities. We invite you to learn more about us and membership of ACU at clinicians.org. Today's presentation is part of ACU's Suicide Safer Care initiative, and I'll ask Josh if he can go ahead and put a link to our website in the chat. Our initiative helps to provide primary care providers, their teams, and organizational leaders with a better understanding of how suicide prevention can be implemented within primary care, as well as how we can better support clinicians who may themselves be at risk. In addition to today's office hours, we encourage you to visit our SSC page where you can find a variety of resources, including our suicide prevention toolkit for primary care clinicians and leaders, specialized toolkits for pediatric and geriatric suicide prevention, organizational approaches to address suicide risk in providers and staff, archived webinars, and much more. As Dr. Little may mention as well, we also offer trainings and technical assistance to health centers too. Before we begin, I also just want to go over a few quick housekeeping items as well. First, if you encounter any technical issues today, please reach out to my colleague Joshua Chung, who is also on the line for assistance. Second, we will be recording this session and we'll send all attendees a recording and slides within a week of the webinar. Today's presentation is a dedicated Q&A, so please don't hesitate to ask any questions that come to mind. You can ask via the chat, the Q&A, or raise your hand to be unmuted. At the end of the session also too, please be sure to complete the very brief evaluation. It's really helpful. Lastly, I am honored to introduce today's speaker. Dr. Virna Little is the co-founder and special advisor for advocacy and research at Concert Health. She is also the chief operations officer and co-founder of Zero Overdose, as well as a member of ACU's advisory council. She is a nationally known expert in suicide prevention, a faculty member for Zero Suicide, and previously served for over 2 decades as a senior vice president for a large FQHC network in New York. We're honored to have Dr. Little presenting with us today. And with that, I will turn it over to her to begin our session.
Well, hello, everyone. I'm really excited to be here and really excited to be able to answer your questions or to have some good discussion. So I know that organizations, health centers are thinking about suicide prevention from a couple of different lenses. So first, we want to think about our patients. How are we caring for them? What are some of the evidence-based ways to be able to care for patients at risk? How are we tracking our population? So are we putting suicide risk on the problem list so that we know our population? Are we thinking about what happened? What evidence-based tools are we using? The Columbia scale. How are we assessing risk? What does that look like? Who's able to do that? And we've been privileged to be able to train a lot of organizations to be able to do suicide safer care in primary care and pediatric visits, sort of in that 15-minute, primary care visit. And then organizations are thinking about how are we keeping our team safe? Unfortunately, we know we lose a physician a day to suicide. I always talk about how when we were going around the country training, we never went anywhere where there was a residency program where someone didn't come up to me and talk about someone they had lost to suicide. So how are we keeping our people safe, our team members safe? What are we doing organizationally as part of onboarding, as part of teaching and training? What does that look like? How do we really become a suicide safer care, zero suicide organization across the board? Where are people falling through the cracks, both on the team side and then also on the patient care side? And so really interested to hear where all of you are sort of in that process. I see some folks on the phone that I know, and really interested to hear where you are in a couple of organizations. I see Cornerstone on the line, and to answer any very specific questions you have about processes. And I'm really hoping we can get in the weeds. If you have very specific questions about pathways or what tools to use or training resources, then please let me know. And we can certainly have that discussion. So I'm going to turn it over to the group. And again, raise your hand, put questions in the chat if you're feeling shy. And also, we can unmute you. So feel free to do any or all of the above. Oh, I've got questions coming in. Here we go. Okay, and feel free to send them out to myself or to anyone, everyone. That way everyone can see them. But if you feel like you just want to send it to me, then that's fine. I had one come in to me that asks about the tools. So the Columbia scale is written into our electronic health record, and we use that tool. Is that the best tool to use? So actually the Columbia scale, or the CSSRS, is an evidence-based tool for risk assessment. I actually really like it because it has 6 questions and it's color coded. So you can have a different response or pathway to patients that are yellow, or score yes to questions 1 and 2, to orange, and then red, which are questions 4, 5, and 6, which really talk about intent. So most organizations are doing clinical pathways or responses around people's scores to those individual questions, particularly 4, 5, and 6, where there's some intent. There's also the ASQ. The ASQ is, I like the ASQ a little bit better because it's better for children and adolescents. So I use the ASQ for children and adolescents, and it has a really nice guide for parents and caregivers, and also a nursing guide. And it has I think the questions are easier. It has question 5 around, are you thinking about killing yourself right now? So that's a very specific question that, you're able to ask. Seems to work a little bit better, but you could build a pathway off of the ASQ and people who answer yes to question 5. So glad to answer more questions about either one of those tools, but certainly both of them are evidence-based for all ages to be able to use. Is the 988 line equipped to deal with the uniqueness of provider issues? So I would love to answer this question unequivocally, yes. I think 988 does an amazing job. It is national now. More than, I think it was something like 90% of the calls can actually be managed in that one call and don't need follow-up. So I do think actually that people could get the support that they need, because what we know is that someone to be there for someone and to provide someone hope is actually one of the most life-saving things that can happen. And so certainly the Lifeline is able to do that. Interested in learning a process for follow-up when using the PHQ for adolescents. Want to give our staff, nursing, and providers the tools to respond to at-risk patients. So the PHQ-A for adolescents is a little bit better than the PHQ-9 sort of regular adult version. We do know now that the PHQ-9, while it's better than nothing, and we do know that people who answer yes to question 9 are more likely to die by suicide, the question about being thoughts that you would be better off dead or hurting yourself in some way. So we actually do know that those patients are more likely to die by suicide, and also by homicide and other unintentional risk factors. However, more and more it's been shown that the PHQ is not really a good screener for suicide. And given the rates of suicide, we want to make sure that we're very specifically asking about suicide. So this question is specifically for adolescents. So what a lot of organizations do is at the bottom of the PHQA, or after they ask the PHQA, they ask the ASQ, the 5 ASQ questions. And that would actually be a wonderful process. You would be using an evidence-based tool to screen directly for suicide. And then you might have a pathway for the kids or adolescents who answer yes to question 5. But that would actually be a completely appropriate workflow and would work out really well for you. I'm glad to answer. If that didn't answer your question, then let me know, and I'm glad to do that. And I'm going to put the link in the chat. I've realized that I have mentioned the ASQ a little bit and didn't. Might be nice to put the link in the chat. So I'll actually do that now. It's a really nice toolkit that NIMH has on their website that has some nice workflows and some tools that you can give out. So I'll put that now in the chat, and I really encourage you. And so it, I think, is really helpful to do that. And one of the things about, you know, the children and adolescents, if you were going to take what NIMH says, because, you know, the suicide rates in the 10 to 14-year-olds are on the rise, like unbelievable. And so they will say you should really be screening 10 and up, you know, when you see them, and asking very specifically about suicide. So I do actually like the ASQ, you know, for the children and the adolescents. Unfortunately, the U.S. Preventative Task Force recently did not side with standardized screening for suicide, although a lot of us think some of the research they looked at wasn't great. And I would also say your geriatric patients, I really see the geriatric patients being ignored, because people kind of feel like, well, like, of course they're sad, you know, they're older, they're not getting around, whatever. But actually they account for almost 20% of the suicides. And most of them don't get referred to care because everybody kind of thinks that way. Well, of course they're old, you know, of course they're depressed, when in actuality, you know, depression in seniors is actually pretty treatable. Interested in learning more about training for staff at health centers, both for clinical staff and frontline workers, mental health first aid. Yeah, I totally agree with you. I'm a fan of mental health first aid. I think lightning would strike me if I said otherwise, but I do agree that the length is a little bit of a barrier. What I did when I worked in the health center is I took all of our job descriptions and I lumped them into 3 categories for today's discussion: A, B, and C, in no particular. And so my C people were people that didn't have direct patient contact, my facilities, you know, some of those folks, right? Product, IT. And I actually did Safe Talk because Safe Talk was much shorter and was much more specific around suicide. And they just took that once during employment. And then I had my B category that were people who were not delivering clinical services, but who had patient contact, my insurance enrollers, my billing, my front desk, all of those folks. And actually I had someone when I worked in the health center die by suicide, and the last person they saw was the insurance enroller. So after that, I did something much different. And they actually got Safe Talk, and they got some additional information around how to have the conversation. They had some information on safety planning, some very basic questions to ask so that they would know a little bit more information. And then I had my folks that were sort of in direct care, and they learned safety planning. They learned CALM, or access to lethal means. They learned about the ASQ and the Columbia scale, and they took the Columbia scale training. So that was really, you know, what they did. And then we did some refreshers every year as we sort of learned more. And it's really important that those folks get the kind of training that they need. When we were going around and talking to, you know, behavioral health providers and community health centers, almost half of them, 44% of them, said they didn't feel comfortable or competent to care for someone at risk for suicide. And as I go around and I look at safety plans, and most of them are not actually sort of quality safety plans, because safety planning is a clinical intervention. And so really making sure that we're giving people the training that they need, but that's how I do it. So you particularly mentioned CHWs, community health workers. It is in scope for them to be able to do the Columbia scale or the ASQ. So they were always trained, because if someone made a suicidal statement, I wanted them to do one of those tools right away, so that they could call a supervisor and they could say, this person made this statement, they have this history, and they scored yes on questions, you know, 4, 5, or 6, or no on questions 4, 5, or 6. And they were also trained in some safety planning, so that they knew what safety plans were. They didn't create them with patients, they just reviewed them, so that every time we saw someone, we at least reviewed training, you know, we reviewed the safety plan. And so that is actually really helpful. Someone asked about where you could get some training for staff. So there's a couple of resources that are really helpful. One of the things around the Columbia scale is the training on zero suicide. So if you go to Zero Suicide website, there's actually a CSSRS training there. Technically, you're supposed to be able to take that training before you do the Columbia scale, but it is actually there, and you can get that training. There's also the CALM training there. The access to lethal means is really helpful, and anyone can go in and take those trainings. And also, if we have some behavioral health folks or others on the line, I like the Now Matters Now website. I'll put it in the chat. And on that website, there's actually some really nice stories. There's a training for primary care providers there, and there's also some DBT skills training for behavioral health providers. It's also a nice evidence-based resource for patients as well. So hopefully that answered the question, but Safe Talk might be a nice training to look into. That's actually shorter in duration. And also ACU does the Suicide Safer Care for primary care providers and their teams. So actually those folks often sit in on that training as well, and it's really helpful for them, because some of the things that you really want, like your front desk, and as example, everybody, but your front desk to know about language, right? That we say die by suicide, we don't say commit suicide. That we're an organization that talks about suicide, we say suicide. You know, we're an organization that knows that asking people about suicide doesn't give them the idea to die by suicide. So really knowing that. And thank you, Rick. That's why we're partners, because he is so good. Put that in the chat for me. He's so efficient. So any other thoughts? We've had some questions about caring for patients. And one of the things that all of the health centers really need to think about, you shouldn't have suicide policies. We don't really do suicide policies. We do suicide pathways. And on the Zero Suicide website, there's some good pathways so that you can actually see them. And it's really less about who does it versus what do we expect to happen in caring for someone at risk for suicide. So you should really think about what a pathway would look like, and people that are on your pathway are the people that are at risk for suicide at any given time, kind of like a diabetes registry, right? That you have this registry of people who are at risk for suicide, and if it's on the problem list, you can resolve it and then know about it, and it can sort of be historical, right? So, you know, I have diabetes, but my A1C, go me, right, has been really good. So I actually am going to hopefully get diabetes taken off my chart, right? It's going to become historical for me. You want to know it's there because I'm at risk for type 2 diabetes again, right? It's there. You want to know about it in my history, but it doesn't need to be on the active list. And so suicide is very much the same way. I could be actively at risk for suicide, and when I'm not acutely or at risk for suicide, it can get resolved and be historical. I'm always going to be more at risk for suicide the rest of my life, so it's good to know about. And so adding it to the diagnosis list helps you really track your population, and you don't really know how many patients you have at risk until, you know, you actually start to track. Let me just. What is the difference between contracting for safety and safety planning? I've seen FQHCs use both. I love this question. So we don't do contracts for safety anymore. They're actually dangerous. They are not a best practice. They're not effective at preventing people from dying by suicide. So contracting for safety, think about it like your diabetic patients, right? Like, I will not eat Ringdings and Mountain Dew, or I will not, you know, I will not smoke, right? That doesn't actually work. It's not really going to help me, you know, to sign something like that. And so we've shifted because people used to think about it that would help with liability, but in actuality, it doesn't, and it's not helpful for people. In fact, it's the opposite. And so safety planning is something that's way more interactive. And safety planning is actually a clinical intervention that's been shown to save lives. So there's two safety plans that are evidence-based. One is on the Now Matters Now website. It is, I call it the emergency safety plan, or kind of the what's on fire. We were always taught what to do if we caught on physical fire, right? We stop, drop, and roll. Nobody ever told us what to do if we catch on emotional fire. And so that safety plan in the Now Matters Now, I call it like your emergency safety plan for people at risk for suicide. And so a lot of times for my people that are historical, you know, maybe I tried to die by suicide when I was an adolescent. I'm always at risk. So you want me to have something. So maybe you give me that safety plan. The most commonly used safety plan, and the one that's probably in your electronic health records, is the Stanley and Brown safety plan. The Stanley and Brown safety plan has information where we can put activities, things that, you know, might put me at risk, people that I can call. And that actually is evidence-based, and that's a safety plan. And so the ability to have all of that information in one place is incredibly helpful for people, and has been shown over and over again to save lives. There are some apps like My Safety Plan and some of the others that are helpful for people, but probably in your EMRs is the Stanley and Brown safety plan. So hopefully that answered your question about contracting for safety and for safety planning. We actually do a training for behavioral health providers and nursing. A lot of times do safety plans, how to really do a quality safety plan. and what to look for. So if people are interested in that training, you can reach out to Rick and he can coordinate with you, to be able to set that up. And I would also say that it's super helpful to think about the safety plans and how you're sharing them with patients, that they're available on the portal and really get to be used. Thank you. These are fun questions. A lot of pressure though to be able to answer these questions sort of off the top of my head. So when is it appropriate to send people to the emergency room? Great question. So what is not appropriate is to send everybody who talks about suicide to the emergency room. We actually know that it's not helpful and can actually put them at more risk. A lot of people will still send, a lot of practices will still send patients to the emergency room if there's any thought of suicide, a lot of times because they think about liability. And the reality is the research is out there that says it could actually be more dangerous for people. But one of the best things you can do for liability is follow evidence-based practices. So you ask people directly about suicide, and people that answer yes, you have a pathway and a process that you use all the time. If I answer yes to, question 1 and 2 on the Columbia scale, I get information on 988 and someone helps put it in my phone. I get a link and someone tells me about the Now Matters Now website. So now I've got 2 evidence-based interventions available 24 hours a day to me. And then I get an emergency safety plan. If I score orange, I get all of those things, and maybe someone sits down and does a Stanley and Brown safety plan with me, is something a little bit more comprehensive. If I score red, then somebody sits down and does a full assessment, or maybe I do need an alternate level of care because I've shown some intent. And so if you have those pathways and processes in place, then that's the absolute best thing you can do in terms of liability. Because you're following some of what are our best practices and using evidence-based tools. So I would really encourage you to do that. And if there's any health centers, we've thought about doing like a little learning community to help, like 1 to 3 sessions just to help organizations put together a clinical pathway. Then reach out to Rick and we can get on the phone with you or do some individual work. And so, we can certainly be helpful with that. Should be concerned and question if an adolescent says, I'm going to kill myself after they lose a game or if they mess up on something they're doing. So you should never not be concerned. But what you can often say is, when a lot of people die by suicide. And so we want to make sure that you're not thinking about suicide, because thinking about suicide is very serious, and I love you and your life is important to me. And so you just made a statement about killing yourself, and I want to ask you very specifically, and then you can ask the question from the ASQ, are you thinking about, killing yourself now? Are you thinking about dying by suicide now? And a lot of times they might say, no, I just said that. And yes, it is very popular. And that's because suicide is unfortunately very popular. And I would say to them, listen, it's really important to me that we be able to talk about suicide. And so if you're thinking about dying by suicide, I want you to come to me and tell me that you're thinking about dying by suicide. And then let's think about another term that we could use and try to do some reframing. So here's what we say if we're just, upset, and here's what we say if we think about, we're thinking about dying by suicide. But yeah, and it's important to really call it out and say, because we know people have died by suicide, and we know that it's very serious. And so we want to make sure that we're not doing anything to support that. Give a moment for people to put in some questions. I'm just gonna take this moment to shut my window. They've apparently decided to mow my lawn. So 1 second while we're putting in questions. Sorry about that, everyone. When is behavioral health engaged during the primary care visit? So, this really depends on your resources. And I would encourage you to think about two things. So one is, the first time that you identify someone that might be at risk, right? Oftentimes what happens is if somebody answers yes to question 9, let's say, or answers, yes to a suicide question, the primary care provider will actually ask them. So I see that you reported that you were having, thoughts that you would be better off dead or hurting yourself in some way. And then they will actually ask them the 6 questions from the Columbia scale. If somebody is yellow or orange, they could then, make a behavioral health referral and give them Now Matters Now in the Lifeline. If somebody scores red, then that's somebody who likely would benefit from having a more comprehensive sit down and a more specific discussion. And so then I would say, I have someone on my team that helps me care for my patients who talk to me about suicide, and I'm going to have them come in and just talk to you a little more today about your thoughts of suicide. So it doesn't mean every single visit it is necessary to get behavioral health involved. If you can do a handoff, great, but if not, for those yellow and orange patients, and they may also already be in care, it depends. I would say also then to have a process for follow-up, because if I'm in behavioral health, even in your internal behavioral health or external behavioral health, I'm still going to come back for that diabetes visit. And so you want to then ask me about, am I safe, right? Maybe you ask me question 6 from the Columbia scale, or you ask me, so do you have your safety plan? Has it changed, right? And you're doing that kind of follow-up. Do you need to talk to everyone about lethal means? The answer is yes. You should probably know how somebody either tried to or is planning to die by suicide. And it's important. There's a couple of things. One is because if I, tried to die by suicide and use medications, that's important information to know, right? Like for prescribing and other pieces. The other thing is that if we can keep someone safe from their lethal means, right? Like you can keep me safe from medications, I'm not likely to switch means. I think because it gives people hope. So it is important to do that. It's also important to talk to people about guns in the home. The reality is many of the people, and I just saw the new data the other day, they, I forget what some of the data was now, but irregardless, a lot of the people who die by suicide use guns. And so it's really helpful to be able to ask people, do you have guns in the home? Many of my patients talk to me about suicide. I want to make sure that you're not thinking about dying by suicide and using your gun. And so that would have you think about, asking that question. I know in some states it gets a little bit dicey in terms of some of the language that you can use, but certainly for our adolescents. So for adolescents, the thing about adolescent suicide is that it's very lethal. Guns, hanging, and jumping from buildings, depending on sort of geographically where you live. And also geriatrics. A lot of geriatric patients die by guns. You see the numbers go up. And I think because they're accessible and they're in the home, they're right there, right? They don't have to go anywhere. So it is important to talk about guns and talk about lethal means. And also, I really try to ask people, you talk to me about dying by suicide and using your gun. Where would you get the gun? So in some of the rural areas, they've actually had adolescents die by suicide because they locked the guns up, but forgot about the one on the mantle, right? Or forgot that the neighbors have guns. And so it's important to ask, where would you get the gun? Where would you get the medications? I like to ask it a little bit in the past tense. If we would have kept you from dying by suicide today, what would we have done? And so sometimes it's easier for people to think about what they would have done versus what they need to do. Sometimes that gets a little bit overwhelming. Really nice questions. So I'm wondering also about being a suicide safer care organization. We had one question about providers and 988, but also, what about your human resources? Are we letting people know when they come on information about suicide for our residents? Are we letting them know what resources are out there about 988 or Now Matters Now? Are we giving them information on the behavioral health benefits for the organization, how to access them? Does our EAP program, if we have one, are they trained and really able to care for people at risk for suicide? A lot of times our front desk or some of our other staff don't think they can afford care. So here's, do they know about the Lifeline? Do they know about some of these other resources that might be accessible to them? And giving that information. A lot of organizations are doing like an FAQ. Here's our behavioral health benefits. Here's a number to call. Here's 988 and here's Now Matters Now. The information is confidential. It's not going to come back to your manager or, to us as employers. Here's the average cost so that people have that information up front. And also to train managers or people what to do. So if I'm, sitting, if I'm a nurse and I'm sitting there and I see, someone comes to me and says, so-and-so from our team is actually just made a suicidal statement on Facebook. What do they do with that information? Or someone just said, that they're thinking about dying, or I'm concerned with someone just made a suicidal statement, that those managers then know what to do, that they know the questions of the Columbia scale, that they have some resources at hand, that human resources knows what to do. I had one time a health center, and you can't even make some up. They actually put someone who made a suicidal statement in the supply closet because they wanted to keep her safe and they didn't want her to leave. And so, really making sure that people are trained. So, questions that you have about how do you, think about suicide care as an organization. And also postvention. I know a lot of you do the hazardous vulnerability assessments. I know when I worked in New York City, we spent a lot of time like, what happens if a subway went off the, platform and into the health center? But in actuality, we could have spent time talking about what if someone died by suicide, right? What if we had a patient or a staff person died by suicide? It was a health center in New York that lost a nurse practitioner to suicide, right? So, do we think about the email we would send out to the team beforehand? Is it crafted so that the CEO or a senior person can send it out? Do we have a way to identify people at risk? If we have a provider die by suicide, everyone becomes more at risk. All of the patients who are identified as suicide risk become more at risk. Any staff who have a history become more at risk. And so really thinking about who is actually more at risk and how are you going to identify them? If you don't know who's at risk in your patient population, then you're not going to be able to identify them. What patient populations are most at risk? Are you seeing any trends in the most recent data? Yeah, boy, the 10 to 14-year-olds. They are actually definitely on the rise. It's one of the leading causes of death. Also, adolescent males of color have higher rates. You're seeing increases there. And then geriatric patients. And of course, certain subpopulations. Of course, we lose way too many veterans to suicide. They're actually seeing a lot of correlations between chronic pain and suicide. So I would think about, we just did a really nice webinar on chronic pain and suicide and depression and anxiety. So I would say definitely to think about that population. And of course, your LGBTQ population, particularly adolescents, are way more at risk. The other piece, people may not be aware of is that many people who die by suicide don't have a mental illness at time of death. And I know a lot of you are doing like the prepare and screening for social determinants, and there's a lot of attention being played to social determinants. And social determinants actually are a huge risk factor for suicide. And the employment, the housing, the relationship, the economics are all risk factors. And so if you have individuals that have multiple social determinants, a lot of you are saying, well, that's like our whole population. But if something dramatically changes, if I had housing, even though it was not stable, I was couch surfing or something, and then I lose it. If I had a job and then lost it, or I had some income and then I lost my disability, those kinds of things are often problematic. And patients going through transitions. Patients who are going through transitions are way more at risk, coming out of the hospital, substance abuse, incarceration, rehab, a geographic move. Those individuals are all way more at risk. That was a really long-winded question to your answer to your question. But yeah, so certainly some things to think about. And also, we spend a lot of time screening for depression. Anxiety now is screening is recommended, the U.S. Preventative Task Force. But anxiety is a huge risk factor. And oftentimes we're caring for people with anxiety and they're, they can't sleep. And, we're talking to them about all these discussions. But a lot of times we're not asking them about suicide, and to just remember that anxiety is actually a risk factor for suicide.
Virna, I just thought that we had another question come in. Someone is asking, how are dentists and their ancillary staff included in awareness, education, and access to resources for help in relation to suicide prevention?
So I actually think of, dental. I, worked in health centers for so many years where dental was part of the team, right? We had dental sites. We did a lot of dental, practices. And so really thinking about them as part of the team. One of the things that often was interesting to me was that many people didn't look at or came in because they had a dental problem and weren't actually connected to primary care or behavioral health. And oftentimes that actually was a problem, and we never screened them. A lot of them were uninsured, and we never actually screened them for preventive health measures or for depression. And so that was something that we really started to do about. Dentists themselves, and actually dental providers, do have a high risk of suicide. There was actually something that got put out a couple of years ago. I just looked it up. It came out in 2016, suicide rates by industry and occupation. Healthcare at that time was 11th, although it's higher now. But there was something done a few years ago that actually had dental raised or flagged as being a little bit of a higher risk. So I can certainly look for that data, but I always think it's really important that if somebody comes into dental and they're not connected to other places, that we actually ask them about it. And I'm just looking it up. Dentists were 2.5 times as likely to die by suicide as members of the general public. So we can certainly look some of that up. I don't have the dental and suicide rates off the top of my head, but that's actually something we should think about because certainly most of our FQHCs and community health centers have dental sites. So thanks for flagging that. What do we do when safety planning and the client patient refused to list an emergency contact and stated that there is no one that can be called? So sometimes I will move away from that question for a moment because they're just feeling overwhelmed or hopeless, or, you know, they're being difficult. Sometimes people have had really bad experiences when they tell people they're at risk for suicide. The police get called, they go in handcuffs, they have to take all the clothes off and sit in an emergency room. And so I sometimes will move away from that for a little bit. And I say, you know, tell me about some activities that you really find helpful. Well, I like to listen to music. What music do you find helpful? Well, I really like to listen, you know, to the Rolling Stones. Tell me, you know, do you have a Rolling Stone soundtrack that you use? Do you have like Spotify, or do you have something? What about the Rolling Stones, you know, do you find helpful for you? Like, I really kind of go there, explore it. I make sure that I put it down and we talk about some activities, and then, you know, I pull up the Now Matters Now website and I let them know that that's there, and then I put that down. And then I say, you know, I really, you know, your life is very important to me, and I really want to make sure you're safe. Who's the one person, you know, that kind of always knows where you are? Or that you check in with the most, or you know, you feel the closest to? Oh, well, you know, that's my aunt. My aunt has always been my rock. Is your aunt someone that we could put down on your safety plan? So I kind of come around it a little bit in the back door. And if somebody really says no, then sometimes I'll ask them, you know, sometimes I find that when people don't want to share the information, there's two reasons. One is because they think it's not important to put the names and numbers here, that they know them. But what I know, and I've heard people tell me, is sometimes when they're just not feeling good and they're, you know, really thinking about suicide, that it's hard to think and remember things. And so it's really helpful to have them in one place and written down. And also it's nice to be able to look at something and know that you have so much support with people and activities. And so sometimes I'll actually say that, and, you know, that's often, you know, helpful for people to say, yeah, well, you know, yeah, I guess so. And I can put them down there. So those are a couple of things that I really do try. And if someone really doesn't have anyone, then I say, well, you know, we're really incredibly lucky to have the Lifeline. Have you had an opportunity to call the Lifeline? If not, I actually let them do it right then and there. And that's often helpful. A registered asked this about what options are there for rural healthcare. So I really, I've done a lot of work in rural settings, you know, Alaska and Montana and Wyoming and even upstate New York. There's some pretty rural areas. And so I think one is really having a suicide pathway so that your providers and know, okay, someone, you know, could be at risk for suicide. I'm going to ask the Columbia scale based on that. I'm going to have some responses. It could be that I just use Now Matters Now and the Lifeline and we're good. that there's a basic understanding of safety planning so that that can happen, because, the access to behavioral health care might be limited. I also will say that there are really some very good resources now that are virtual, like Charlie Health. Charlie Health is great. Charlie Health is an intensive outpatient program for young adults. They start in early adolescence and go up to age 33. It's all virtual. They do such a nice job. They care for people at risk for suicide. They take, insurances. And so, there are a lot of resources like that now, Ophelia and Charlie Health and some of the others. So hopefully we're starting to get a little bit more. The other, I would say, are the collaborative care codes. So if you work in a state where Medicaid has passed the collaborative care codes, you should totally be doing collaborative care, which is an evidence-based model to identify and treat patients with depression and anxiety in healthcare settings. And so that actually is a monthly case rate, and it allows you to do a lot of the phone follow-up that's really helpful for people. And also in rural areas, where transportation is an issue, then that's often helpful. So for those without healthcare that are just in community-based organizations or don't have, do you mean healthcare or health insurance? So without health insurance, certainly, some of the state and federal resources, the lifelines and all of that are available to people.
And Virna, I'm seeing a question from Sherry Brown. She's asking, what about those without healthcare?
Yeah, that's what I just said. I wasn't sure if she meant without healthcare or without health insurance. And so certainly without health insurance, there's some of the federal or state, the 988 and that. And so someone without health care, then certainly, one of the nice things now is that our health centers can certainly care for people at risk for suicide and take patients. If someone doesn't have any care, then I would certainly want to connect them. And if they're not wanting to go, then to connect them to something virtual, like the Charlie Healths, like the, Lifelines, all of those folks. Also the Suicide is Different website is really nice for family and friends as well. But it's important to get them connected and give them resources. Like they definitely need to be connected somewhere to be able to have some support. I want to make sure I got all the questions. Any questions about organizational preparedness? I know we've got folks on the line from the teaching health centers. I did something one time in rounds where I asked questions and residents, gave a survey, and I was really surprised, or maybe not, about the depression, but also the suicide, that there were people in the room that, were thinking about suicide. And so, I think it's really important to ask and to let people know what the resources are, let residents know, let medical students know what the resources are, talk to them day one about suicide. And, ACU is really very excited to provide support. So if organizations, again, want to train their primary care teams on, suicide safer care, it's an hour-long training. If you want to do something special and more dedicated for your behavioral health providers around safety planning or suicide care, then, that's an option as well. If you wanted to have some consultation around what to do organizationally, that's an option. So we're really here to support you as you go on this journey. So what training resources are available for ambulatory case managers who only have a telephone or video contact with patients and who mainly only occasionally encounter patients who are having active thoughts of suicide? I actually think that it's important to be able to give them training both on the Columbia scale and ASQ, and then also on safety planning, because particularly ambulatory case managers, particularly those who are caring for people with chronic illnesses, we know that there's a high comorbidity, or people who are getting hospitalized and transitioning out. So I would encourage to be asking very specifically about suicide, maybe when you initially meet someone. And then if somebody made a suicidal statement, that they're trained to do the Columbia scale or the ASQ, and some safety planning, which is completely in scope or based on what the scores are on the Columbia scale, that they have something they can do for the yellow and orange patients and another process they do for the red. Nice questions, though. What do we do when safety planning and or the client patient refuse? Okay, no, we did that. Okay. Do we have templates and quick reference guide to institute with our organizations? Yes. They're on the Zero Suicide website, and then we can also share, there's things that are called pathways, and I'll pull it up now. You can actually see this is an example of a clinical pathway. How are we identifying somebody? What are we doing? How are we measuring, right? How are we tracking people on our pathway? What are some of our definitions? What do we expect to happen when we identify someone, when we're caring for them, sort of ongoing? And so I really encourage you to think about the care pathways. We can share this, we can help your organization. Those are actually on the Zero Suicide website, or we can share and be supportive. But the Zero Suicide website has a lot of good resources. And if you have any trouble finding anything, then reach out and we can certainly help you. So I know we have 1 minute left. Rick, if you want to say any closing words, and I just really want to thank everyone. These were really, really good questions. I really enjoyed answering them. I really hope you know that we're here to support you and be able to help you put some of these systems in place. So Rick, I'll turn it over to you.
Absolutely. Thank you, Virna. So just to finish up, I just wanted to thank everyone for joining us, and also just to mention that you please feel free to reach out to us with any inquiries. As Virna mentioned, we do provide technical assistance and trainings through our Suicide Safer Care program. You can also visit the link, which Josh will put into the chat as well. We have a variety of archived webinars and other resources as well. Lastly, we also hope you'll join us later this year for some further upcoming webinars we'll have. We'll be addressing not only racial inequities in youth suicide, but also addressing the risk of clinician suicide itself. So stay tuned for this, and thank you so much again for joining us. We hope you have a wonderful day.
Thank you, everyone, and thank you again.